Bismillahirrahmanirrahim. So let's continue from where we left last time. We were talking about the brachial plexus injuries. So upper brachial plexus or the Erb Duchenne palsy. So what happens in Erb Duchenne palsy is that in all cases, paralysis of the muscle of the shoulder and the arm supplied by C5 and C6 spinal roots of the upper trunk. So that is happening in the upper brachial palsy. In all the cases of the upper brachial palsy, the paralysis of muscle of the shoulder of the arm which is supplied by the C5 and C6 spinal nerve roots will be there. Combination of lesions of axillary, the suprascapular and the musculocutaneous nerve with the loss of shoulder what does that mean? Shoulder and anterior arm, shoulder muscle movement. Okay, so there is loss of shoulder. Is for the muscle movement and the anterior arm. Okay, the as a result the patient has Vater strip over there. This this posture is called as the Vater strip hand. There will be adducted shoulder, okay, medially rotated arm and the extended elbow. The loss of sensation in the lateral aspect of the upper limb will also be there in the case of upper brachial palsy. So which nerves are being damaged? They are talking about the damage to, just let me clear this all. So they are saying that there will be damage to the, there will be mixture of damage to the musculocutaneous nerve, the axillary nerve and the suprascapular nerve, which are originating from C5 to C6 nerve roots. So these three nerves are coming from that. So there will be a mixture of the paralysis of these three nerves, and resultantly a Vater strip hand will be formed, and that is an adducted shoulder, medially rotated arm and the extended elbow. Loss of sensation in the lateral aspect of upper limb will also be seen. We will see all these things in detail when we do the FA sessions. So let's keep going on because otherwise it will take very long. Lower brachial palsy, that is going to cause the Klumpke's paralysis. So the upper one is going to cause Erb Duchenne palsy and the lower one will be causing the Klumpke's paralysis. Injury to the lower roots of the trunk, injury to the lower roots and trunks may occur when the upper limb is suddenly pulled superiorly, stretching or tearing of the inferior part of the brachial plexus, that is C8 and T1 nerve roots that are inferior trunks. For example, grabbing the support during falling from the height or as a birth injury, or TOS, thoracic outlet syndrome. There is something coming out of the thoracic outlet. For example, there is Pancoast tumor or something like that. So even in that case, there can be damage to the lower roots, that are C8 and the T1 roots, which can be damaged, and they may result in the Klumpke's paralysis. So if you see in this picture, these two are the upper roots. They are damaged in the Erb Duchenne paralysis. The lower roots, they can be damaged in the Klumpke's paralysis. Okay, so remember this thing. May occur when the upper limb is suddenly pulled superiorly, stretching the tearing. Okay, so like that, and maybe like that if the arm is being stretched outwards to deliver the baby. Grabbing support during falling the height and or as a birth injury is depicted in the picture, and also the thoracic outlet syndrome. What is lower brachial palsy? The Klumpke's paralysis. We are still on that. Yep. So all the intrinsic muscle of hand supplied by C8 and T1 roots of the lower trunk are affected in this case. All the intrinsic muscle of hand which are supplied by the C8 and T1 nerve roots will be affected. A combination of lesion of the ulnar nerve, that is ulnar claw hand, and the median nerve, that is ape hand. I guess we saw that in the previous video. So the ulnar claw hand and the median ape hand will be seen in this picture. So this one is, I guess, I don't know what that is. Loss of sensation in the medial aspect of the upper limb and the medial 1 and 5 fingers. Okay, so the loss of sensation in the medial aspect of the upper limb. Okay, and first and fifth finger maybe. So they may include the Horner syndrome, because if there is thoracic outlet syndrome, so there is Pancoast tumor, suppose, that is coming out of the thoracic outlet and that is obstructing the lower roots. So those lower roots can also be affected along with the paravertebral sympathetic ganglia, and if those are affected, so it can result in the Horner syndrome, that is anhidrosis and meiosis and ptosis in the ipsilateral side of compression of the sympathetic trunk. So that is Horner syndrome that can occur along with the lower root paralysis of the brachial plexus, that is Klumpke's paralysis. So remember this thing, and I just cannot understand this point. Loss of sensation in the medial aspect of upper limb. Okay, got it. Medial aspect of upper limb, and the medial 1. Okay, so it's not 1,5, it is 1.5 fingers. Okay, because it is ulnar nerve, so there will be a loss of sensation in the medial aspect of the upper limb, that is the ulnar half of the upper limb. Yes, the ulnar half of the upper limb along with the medial 1.5 fingers. Yep, both anteriorly and posteriorly. So remember this thing. Then may include a Horner syndrome. So let me show this over here. So you see this is the distribution of the ulnar nerve, the blue one. So this one, and the posterior is also over there. So medial 1.5 digits are involved with the are involved whenever there is any damage to the ulnar nerve, for example in the case of a Klumpke's paralysis or the damage to the lower root of the brachial plexus. Okay, coming back, now we are talking about smart table 2, that is nerve of the upper limb. So axillary nerve, the root value is C5 and C6 as we have previously seen. Same is for the musculocutaneous nerve as well. So axillary nerve innervates the region, it innervates the deltoid muscle, the teres minor and the shoulders region skin. The clinical sign is loss of abduction. So if there is loss of abduction, so it means that there is some damage to the axillary nerve. Okay, so when there was Erb's paralysis, we saw that the person was having an adducted shoulder because there was damage to the axillary nerve maybe. So secondly, we have musculocutaneous nerve, flexors of the arm and skin of the lateral forearm. So flexors of the arm, which include the biceps, biceps brachii, and along with that other flexors as well. Okay, and the skin of the lateral forearm. The weakness of flexion and supination in the elbow will be seen as a clinical sign. The weakness of flexion and supination in the elbow. The radial nerve, that is C5 to T1 nerve root value. Extensors of the arm are being supplied, forearm and the posterior skin of the upper limb. So extensors of arm and forearm are being supplied by the radial nerve and the posterior skin of the upper limb. Okay, so the clinical sign which can be associated with this one are the wrist drop, loss of wrist sensation. Okay, so let's see it. We're talking about the axillary nerve. So for the axillary nerve, it is like axillary median nerve and ulnar nerve, and then we have the radial nerve in the forearm and hand. Okay, so it's axillary nerve, ulnar, musculocutaneous nerve, then artery nerve. Okay. So there is no separate diagram for the axillary nerve, I guess. It is on the Netter atlas. So axillary nerve is over here, and there's the cut section of that. Ulnar nerve, and then radial. Okay, then radial nerve in the forearm. Okay, so there is no separate description for the axillary nerve, but remember that axillary nerve is supplying the deltoid muscle, and also it is okay. So it is supplying the deltoid, the teres minor, and the shoulder region. Okay, talking about the musculocutaneous nerve. Now let's look at the musculocutaneous nerve if we have a picture of that. Okay, so musculocutaneous nerve is over here. So these are the muscles which are being supplied by the musculocutaneous nerve. Musculocutaneous nerve will be supplying the bicep brachii muscle like this one, then the coracobrachialis muscle. Along with that, it is supplying the brachialis muscle. Then the articular branch will go to the bones, I guess, and then this is the zone of supply for the musculocutaneous nerve, that is supplying the cutaneous innervation by the lateral antebrachial cutaneous nerve to the lateral aspect of the forearm. Okay, so it is supplying the lateral aspect of forearm, skin of the lateral forearm, definitely. Then radial nerve supplies the extensors of arm and forearm and the posterior skin of upper limb, posterior skin of the upper limb. So let's see that in the picture. Talking about the median nerve, and then we have the radial nerve over here. So this is the radial nerve. It is supplying a lot of muscles. So remember, the extensor compartment of the arm and the forearm is being supplied by the radial nerve, and it is supplying this red area. So the red area, that is the posterior aspect of the arm, forearm, and hand. So the whole of the upper limb, the posterior aspect of the upper limb is being supplied. The cutaneous innervation to the posterior aspect of upper limb is being supplied by the radial nerve, and here you can see the axillary nerve as well. So superior lateral brachial cutaneous nerve is coming from the axillary nerve, which is supplying the deltoid region maybe. So remember this thing. Then moving back to the median nerve. Median nerve supplies the flexors of forearm except 1.5. So 1.5 and 5. So what does that mean? They've just given a star and no explanation to that. So 1.5, 5 of the hand, 3 thenar plus 2 lumbar. So flexors of the forearm. Median nerve is supplying the flexors of the forearm and 5 muscles of the hand, which are 3 thenar and 2 lumbrical muscles. So 3 thenar muscles and the 2 lumbrical muscles. Okay, so if there is any damage to that, it may result in the ape hand, loss of the thumb apposition. So the radial nerve damage can result in the wrist drop. Okay, so wrist drop will be seen in the radial nerve damage, and for the median nerve we see the ape hand deformity. So if we see that in the picture of Netter atlas, median nerve is ulnar nerve, and then we have median nerve over there. So this is the area of supply for the median nerve, like the lateral part of the hand. So it is supplying the cutaneous innervation to the lateral 2/3 maybe of the hand, so lateral aspect of the hand, and along with that, first 3/5 of the 3.5 fingers, so 1, 2, 3 and 3.5 fingers are being supplied, and the lateral aspect of the palm is also being supplied by the median nerve, and it is supplying the thenar muscles over there and the lumbricals, like 2 lumbricals and 3 thenar muscles. So first 2 lumbricals and the thenar muscle are being supplied by the median nerve. So if there is any damage to the median nerve, we get an ape hand. Ulnar nerve, the root value is 3A to T1, it is supplying the flexors of hand except 5. Okay, 1.5 forearm, that is flexor digitorum ulnaris, flexor digitorum ulnaris, and 0.5 of flexor digitorum profundus. Flexor digitorum ulnaris. Is there a muscle like that? I don't remember like any muscle in flexor digitorum ulnaris. Okay, so FDU muscle. It is that is not that is FCU. That is flexor carpi ulnaris. That is not flexor digitorum ulnaris. It is going to supply the flexor carpi ulnaris or 0.5 flexor digitorum profundus, and you need to remember none of that. So remember that ulnar nerve is, if it is damaged, it can cause claw hand, that is clawing of the digit 4 and 5. Okay, so let's see the picture of the innervation of the ulnar nerve. So it is ulnar nerve, and it is supplying the medial one third of the hand, the medial one third of the palm, and 1.5 fingers as well. The medial 1.5 finger is also being supplied with the ulnar nerve, and posterior innervation is over there. So the long thoracic nerve is supplying the serratus anterior, which can cause wing scapula if it is damaged, and suprascapular nerve is going to supply the supraspinatus muscle, and pain and problem with the initiation of abduction, because initial 15-degree abduction is caused by the suprascapular muscle, and if there is damage to that, resultantly there will be pain and problem with the initiation of abduction. So we have seen these all nerves, all the nerve axillary, musculocutaneous, radial, median, ulnar, long thoracic, and suprascapular. I was right previously, I'm sorry. If there is damage to the suprascapular nerve, the supraspinatus muscle will not be able to function properly, and resultantly we will have pain and problem with the initiation of the abduction. Moving forward, we'll talk about cutaneous innervation of the hand. So in reality, in case of superficial branch of the radial nerve lesion, it will be skin deficit between 1 and 2 digits. Okay, so skin deficit between 1 and 2 digit over here. On the dorsum of hand only, because the nerves are overlapping. So practically speaking, whenever there is radial nerve damage, so there will be no it will not be a profound damage to the cutaneous supply and all that. The only damage will be seen in this zone. So because the in reality the nerves are overlapping, and there is no fixed pattern of nerve supply, but for the theoretical purposes and for the hypothetical purposes, we call that the whole cutaneous supply of the posterior hand will be lost. Then palm sensation does not affect in case of carpal tunnel syndrome. Superficial palmar branch come above the retinaculum. We have talked about that previously. So this red area, that is the supply of radial nerve. This is posterior, the dorsal aspect of the head, and the orange one is for the median. Okay, and this is ulnar. The medial. I'm sorry. The ulnar nerve is supplying the medial 1/3 of the palm, both the palmar and dorsal surfaces, while the posterior lateral 1/3 is supplying by the radial nerve, and palmar lateral 1/3 is being supplied by the median nerve. And here is the ulnar nerve supply, and so dorsum 1.5 is ulnar. So dorsal 1.5 fingers is supplied by the ulnar nerve, and 3.5 by the radial nerve. Okay, so it is not fingers, it is basically dorsal 1.5 area is supplied by the you can say dorsal 1/5 is supplied by the ulnar nerve, and 3/5 is supplied by the radial nerve, and palmar 1/5 is supplied by the ulnar nerve, and 3/5 is supplied by the median nerve. So remember it like that. These are important to know dermatomes. So upper limb C6 involve the thumb. Okay, C7 finger 2 and 4, C7 like finger 2, 3 and 4, 2 to 4, and C8 is for the little finger. So C6 involve the thumb, C7 is for the finger 2 to 4, and C8 is involving the little finger. For the trunk, T4 is the level of nipples. Remember this line. Then T7 is at the xiphoid process. Okay, T10 is at the level of umbilicus, and L1 is at the level of pubis. Okay, so fit the other ones in between them. Lower limb, L4 involves the big toe. So this is L4 going all the way involving the big toe. Then L5, 2 to 4. Okay, so S1 little toe. So the pattern of limbs is same. Like over here, there is only one dermatome which is involving the thumb, that is C6. For the 2 to 4 fingers, we have another dermatome, that is C7, and C8 will be involving the little finger. And there is a similar pattern. Number is different, but the pattern is same, that only one dermatome is involving the big toe, that is L4. Then L5 involves toes 2 to 4, and S1 is involving the little toe as well. Then note, dermatome is a strip of skin innervated by one DRG, dorsal root ganglion. So dermatome is a strip of skin that is innervated by one dorsal root ganglion. Remember this. So these are the dermatomal patterns. Remember these things, and then you will put other ones in between them, and you will be golden. So cranial nerve, the V1 is supplying this the forehead, mainly. The V2 is the maxillary branch that is supplying the maxilla, and the mandibular zone is being supplied by the V3. Point number 13 is about cardiac catheterization. The femoral artery is used for the cardiac catheterization. It can be cannulated for left cardiac angiography and also for visualizing the coronary arteries. A long slender catheter is inserted percutaneously and passed up the external iliac artery, common iliac artery, aorta, and the left ventricle of the heart. So they may ask you about the pathway from which the cannula is passing. So the catheter, we make a subcutaneous incision, then we enter the catheter into the artery, and then it passes from the external iliac artery, from external to the common iliac artery. From the common iliac artery is going to enter the aorta, the abdominal aorta basically, and from the aorta it is going to enter the left ventricle. Why left ventricle? Because from the aorta it will go to the left ventricle directly, because aorta is connected to the left ventricle, yeah, and then to the left ventricle of the heart, and then we can do the catheterization over there. Okay, so this is basically anatomy of the heart. So superior vena cava is on the right side, then right coronary artery is over there on the right side, then inferior vena cava. These things are entering on the right heart. The catheter is inserted in the abdominal aorta. So abdominal aorta is entering into the aorta, and then from the arch of aorta it will enter into the left ventricle, and left coronary artery is on the left side of the heart. Then point number 14 is about the injury of the gluteal region, fractures of the femoral neck. So if there is any, so we are done with upper limb. Now we are in the lower limb. So if there is damage to the femoral neck, injury to the gluteal region, fracture of the femoral neck. So what happens in that case? A common fracture in the elderly women with osteoporosis is the fracture of the femoral neck. So this area, this thing over here and here. So if this is the head, so below the head we have the femoral neck, and this neck is commonly fractured in older women who have osteoporosis. So if you can see this line like this one, so this is the line of fracture. Fractures of the femoral neck cause shortness and lateral rotation of the lower limb. Okay, so the lower limb will be shortened and also laterally rotated. Fractures of the femoral neck often disrupt the blood supply of the head of femur. At the present time, the best way in the case of femoral neck fracture is the hip replacement. We do the hip replacement therapy for the fracture of the femoral neck. Okay, so here you can see that due to the fracture, the femur, I guess, has moved upwards, or the angle is reduced. So that is the reduction in the angle is responsible, or straightening of the angle, you may say, that is responsible for the shortening of the leg, and the leg is also externally rotated. Then we have avascular necrosis of the femoral head. Why is there avascular necrosis? Because these are the branches, retinacular arteries from the medial circumflex femoral artery. There are two sides of damage. So let's see that first. Transcervical fracture disrupt the blood supply to the head of femur via the retinacular artery from the medial circumflex femoral artery and may cause avascular necrosis of the femoral head if the blood supply through the ligament to the head is inadequate. Okay, if the blood supply to the ligament, so this is there is a ligament. That ligament is called as artery of the head of femur. So a ligament is attached over there. I don't remember the name of that. So the blood supply to the head of femur is coming from this ligament. If the blood supply coming from this ligament is inadequate, so resultantly the anastomosis coming from the retinacular artery, so the medial circumflex artery, will compensate for that. Now if we have a fracture at this position, that is called as transcervical fracture, I guess. So if that fracture is there, the retinacular arteries will be lost and the anastomosis is gone. Resultantly, if there is inadequate supply by the ligament, so the head can undergo necrosis. But if the fracture looks something like that, so in that case the blood supply is intact. So I guess the blood supply will compensate for the supply to the head, and there will be no avascular necrosis in this case. Moving forward, posterior hip dislocation. So when does that happen? The posterior hip dislocation are most common. Okay, a head-on collision that causes the knee to strike the dashboard may dislocate the hip when the femoral head is forced out of the acetabulum. Okay, so if there is, the knee are striking the dashboard, so resultantly there will be pressure backward, so the acetabulum will be leaving, so the femoral head will be leaving the acetabulum and it will be displaced backwards. The joint capsule ruptures inferiorly and posteriorly, fracture of the ischium, following the femoral head to pass through the tear in the capsule, tearing the ischiofemoral ligament and over the posterior margin of the acetabulum into the lateral surface of ilium, shortening and medial rotating of the limb. So this pattern must be remembered, that in both the femoral neck fracture and this fracture that we are talking about right now, that is posterior hip dislocation, there is shortening of the limbs, but the hip dislocation is associated with the medial rotation of the limb, that is this rotation. The limb undergoes medial rotation, but in the case of femoral neck fracture, the limb was undergoing lateral rotation. So these two things must be kept in mind, and then we'll move forward. Yep. So injury to the sciatic nerve. What happens in this case? weakened hip extension and knee flexion will be seen if the sciatic nerve is damaged. Weakened hip extension and knee flexion, foot drop, lack of dorsiflexion. So there was another drop that we previously seen that was about wrist drop, and wrist drop was seen in the case of a damage to the radial nerve. And now if there is damage to the foot drop, so in the case of damage to the dorsal nerve, to the this nerve, like the sciatic nerve, so there will be foot drop. The flail foot lack both the dorsiflexion and the plantar flexion. The flail foot will lack both the dorsiflexion and the plantar flexion. Causes of injury caused by the improperly placed gluteal injection may result from posterior hip dislocation. Okay, so posterior hip dislocation, as we see, as we have seen in this picture. So even this can cause sciatic nerve damage, but the most common cause is improperly placed gluteal injection, right? So here you can see that we have the sciatic nerve over here, like this one is sciatic nerve, and this is the right sciatic nerve, and iliac crest, gluteus medius muscle is over there. Then safe area, for the safe green areas for the this area. If we divide the gluteus into 4 quadrants, so the upper outer quadrant is the safe area for the injection. It is the safe injection site. If the injection is placed anywhere else, there is a risk of damage of deep structures, and right sciatic nerve can also be involved. Superior border of the greater trochanter and stuff like that. So let's move forward to the smart table number 3, that is nerves of the lower limb. Femoral nerve, that is coming from the L2 to L4. Innervated region is muscles and skin of the anterior thigh, and clinical sign is loss of the knee extension. So there will be loss of knee extension if the femoral nerve is gone. The obturator nerve, the root value is same as that of the femoral nerve, that is L2 to L4. Innervated region are muscles and skin of the medial thigh, and if that is damaged, there will be loss of thigh adduction. Tibial nerve, the root value is L4 to S3. It is supplying the muscle of posterior thigh except half of any muscle, leg and plantar foot. Okay, loss of plantar flexion and everted foot. So there will be everted foot if there is damage to the tibial nerve. So the common fibular nerve damage, that the root value is L4 to S2, half short head of the bicep femoris. Okay, so half of the short head of the bicep femoris is supplied by the common fibular nerve, and if that is damaged, we can find foot drop and inverted foot. So remember that these nerve, tibial and the common fibular nerve, these are branches of the sciatic nerve. So if there is damage to the common fibular nerve, that can result in foot drop. Okay, and superficial fibular nerve, this is also a branch. So common fibular, superficial, and defibular nerve, these two are branches of common fibular nerve. They are supplying the lateral leg muscles, everters, skin of the dorsum of foot. So if they are damaged, there will be inversion of the foot. If the tibial nerve is damaged, we find eversion of the foot. If the superficial fibular nerve is damaged, we find inversion of the foot. The defibular nerve, muscle of the anterior leg and dorsum of foot, and that can result in foot drop. Superior gluteal nerve, that is supplying the gluteus medius and minimus, and if that is damaged, we find the Trendle and Bug sign, which we'll see in the next page. And inferior gluteal nerve is supplying the gluteus maximus. So this is a confusing point, that inferior gluteus is supplying the gluteus maximus and superior gluteal is supplying the gluteus medius and minimus. I can say the picture of that. So gluteus maximus is like over here, medius is there, and then we have minimus somewhere. So okay, so inferior gluteal nerve is supplying the gluteus maximus. Problem with climbing stairs or standing from the seated position can be seen. Inferior gluteal nerve, there will be a problem with the climbing of stairs or standing with the seated position. What is Trendle and Bug sign? The superior gluteal nerve may be injured during surgery, posterior dislocation of the hip, or poliomyelitis. So these are the 3 conditions that can damage the superior gluteal nerve. Okay, paralysis of the gluteus medius and the gluteus minimus muscle occur so that the ability to pull the pelvis up and the abduction of the thigh are lost. So 2 movements cannot be done, that is ability to pull the pelvis up and the abduction of the thigh, they are lost. Trendle and Bug sign. If the superior gluteal nerve on the right side is injured, the left pelvis falls downward. So suppose that this is the right superior gluteal nerve injury. So they have seen that like this is the right side and there is the left side. So if there is damage to the superior gluteal nerve on the right side, the left pelvis falls down. The left pelvis will be falling downwards. Okay, when patient raises the left foot off the ground, so when the patient is raising the left foot off the ground, this pelvis will fall downwards. Note that side is contralateral to the nerve injury. So for the gluteus, if there is damage to the superior gluteal nerve, the contralateral side of the pelvis will be dropped down, and then the person will have to flex his knee or lift his leg upward to move. So this thing is seen in the Trendle and Bug sign. Then point number 15 is about avulsion fractures of the hip and bone. Okay, so hip bone and the hamstring muscles. So what happens there? Avulsion fractures occurs when the muscles are attached to the ischial tuberosity. Okay, so avulsion flexion occurs where the muscles are attached to the ischial tuberosity. Okay, hamstring muscles, bicep femoris, semitendinous and semimembranous, because normally muscles can extend or stretch up to elongate basically. Normally the muscles can elongate up to a limit, but that is not true for the hamstring muscle. They can elongate like for very they can elongate up to the full capacity of the muscle, and after that there is avulsion. So these three muscles are called hamstring muscle, the bicep femoris, the semitendinous and the semimembranous muscles. They can be avulsed from the site of attachment, that is ischial tuberosity. Action is the extension of hip joint and the flexion of knee joint. Nerve supply, that is tibial nerve, short head of bicep femoris, is supplied by the common fibular nerve. Okay, so then we have ischial tuberosity over here, like this one is the ischial tuberosity. Then quadratus femoris is this muscle, and let's see the highlighted one. The bicep femoris is this one. Then we have the semitendinous muscle and the semimembranous muscle, and the sciatic nerve is supplying these muscles. So they can be avulsed from the ischial tuberosity. Structure under the inguinal ligament. What are the structures which are present under the inguinal ligament from the lateral to the medial position? I guess from the lateral, iliopsoas muscle is the most lateral thing. Okay, so lateral to medial position, we have iliopsoas muscle like over here, then femoral nerve, this one is a femoral nerve, this one, then femoral artery, then femoral vein, and then the femoral canal. So from medial to lateral, you can remember it like VAN, van is a good mnemonic, or you may make a mnemonic yourself. So iliopsoas is the most lateral thing, then under the inguinal ligament, then we have the femoral nerve, femoral artery, femoral vein, and then the femoral canal. So remember these things. Then moving forward, we have femoral hernia. What is meant by femoral hernia? Femoral hernia is most common hernia. It is most common in the females. It is not most common among them. The most common type of hernia is the indirect inguinal hernia, but femoral hernia is more common among females. So the femoral hernia passes below the inguinal ligament through the femoral ring into the femoral canal. So it passes below the inguinal ligament through the femoral ring into the femoral canal to form a swelling in the upper thigh, inferior and lateral to the pubic tubercle. So it will form a swelling in the upper thigh, inferior and lateral to the pubic tubercle. Okay. The herniated sac may protrude through the saphenous hiatus into the superficial fascia. Okay. The femoral hernia occurs more frequently in females and is dangerous because a herniated sac may become strangulated, and aberrant obturator artery is vulnerable during the surgical repair. So if there is an aberrant obturator artery, that is vulnerable during the surgical repair of this femoral hernia. And this one is inguinal ligament, and the a lot of things over there. Superficial vein of the limbs. Superficial veins of the lower limb. The first one is great saphenous vein. Then we have small saphenous vein. So great saphenous vein is number one. This one, which is coming from the medial aspect, I guess. So arises from the medial side of the dorsal venous arch of the foot, passes anterior to the medial malleolus, and ascend on the medial side of the leg, adjacent to the saphenous nerve. Then passes in the medial side of the thigh and joint with the femoral vein. So it is passing on the middle side of the foot and ascending upwards, and then it passes in the middle side of the thigh and joined with the femoral vein. Okay, so it is going to join with the femoral vein. While the small saphenous vein, it arises on the lateral side of the dorsal arch of the dorsal venous arch, passes posterior to the lateral malleolus, and ascends to the posterior leg adjacent to the sural nerve. So it is passing adjacent to the sural nerve. It pierces the popliteal fossa to end in the popliteal vein. Okay, so small saphenous vein arises on the lateral side of the dorsal venous arch, passes posterior to the lateral malleolus, and ascends the posterior leg adjacent to the sural nerve, and it pierces the popliteal fossa to end in the popliteal vein. The point number 17 is about knee joint injuries, that is called as unhappy triad. So what is that? Because the lateral side of the knee is stuck more often, for example, in the football tackle, the tibial collateral ligament is most frequently torn ligament at the knee. Because the lateral side of the knee is struck more often, for example, in a football tackle, the tibial collateral ligament is most frequently torn ligament at the knee. That is called as the unhappy triad of the athletic knee injuries, that involves the tibial collateral ligament, the medial meniscus, and the anterior cruciate ligament. So the triad includes the anterior cruciate ligament that is torn, then the medial meniscus, and tibial collateral ligament. So these three things can be torn if there is some damage like that. Foot is fixed and leg is being moved in that direction. So because the lateral side of the knee is struck more often, for example, in the football tackle, the tibial collateral ligament is most frequently torn, this one. And the unhappy triad of the knee joint injuries can involve these three ligaments, or these three ligaments of the knee joint. Then tibial collateral ligament, medial collateral ligament. They said that because the lateral side of the knee is struck more often. For example, in the football tackle, the tibial collateral ligament that is present on the medial side is most frequently torn. Okay, so this is the tibial collateral ligament, the broad band extending from the medial epicondyle of the femur to the medial condyle of the shaft of tibia. So from the medial epicondyle of the femur to the medial condyle of shaft of tibia, we have this broad band extending, this broad band that is called as a tibial collateral ligament. It blends with the capsule and firmly attaches to the medial lemniscus. Okay, it is not lemniscus, it is medial meniscus. Okay, so it blends with the capsule and firmly attaches to the medial meniscus and limits the extension and abduction of the leg at knee. Okay, got it. It limits the extension and abduction of the leg at the knee. So this thing is the tibial collateral ligament, and it is attached firmly to the medial meniscus that is present inside. And then we have patellar ligament anteriorly, and this is the attachment of the capsule. Semitendinous muscle is attached over there, and then gracilis and sartorius attachment is also over there. So fibular collateral ligament or the lateral collateral ligament. Remember these two things. Tibia is present medially, so tibial collateral ligament will also be present medially, and that is the most common type of injury seen in the football injuries. So the most commonly damaged tendon is the tibial collateral ligament, then medial meniscus, to which it is very strongly adherent. Along with that, anterior cruciate ligament is also damaged, and this is the unhappy triad. So tibial collateral ligament is present on the medial side, while the fibula or the fibula is present laterally. So the fibular collateral ligament is also present laterally. So rounded cord between the lateral epicondyle of the femur and head of fibula. Okay, so this is a rounded cord. This is fibular collateral ligament. It is not a broad band. It is a rounded cord between the lateral epicondyle of femur and the head of fibula. Does not blend with the joint capsule and does not attach to the lateral meniscus. So it does not blend or attach with the lateral meniscus, in contrast to the tibial collateral ligament, which blends with the joint capsule. Along with that, it is very firmly adherent to the medial meniscus. Then limits the extension and adduction of the leg at knee. So this joint limits the extension and adduction of the leg at the knee joint. Then talking about rupture of the cruciate ligaments. The rupture of the cruciate, with the rupture of the anterior cruciate ligament, the tibia can be pulled forward excessively on the femur, exhibiting the anterior drawer sign. So it can be pulled anteriorly, and that is showing the anterior drawer sign if there is damage to the cruciate ligament, anterior cruciate ligament if that is damaged. Half the bone is removed in the half the bone is removed to show the ligament. So basically you have cut the bone open, and here you can see the anterior cruciate ligament if that is torn in this side. Let me zoom it in. So the cruciate ligament is torn in this side, so anterior drawer sign will be positive, that is the bone, the tibia, can be moved forward. The anterior cruciate ligament prevents the femur from sliding posteriorly on the tibia and hyperextension of the knee, and limits the medial rotation of the femur when the foot is on the ground and the leg is flexed. So when the rupture of anterior cruciate ligament, the tibia can be pulled forward excessively on the femur, exhibiting the anterior drawer sign. Anterior cruciate ligament attaches to the lateral condyle of the femur. Okay, in the less common rupture, the posterior cruciate ligament, if that is ruptured, the tibia can be pushed backward excessively on the femur, and that is the posterior drawer sign. Posterior cruciate ligament attaches to the medial condyle of the femur. So anterior was attaching to the lateral condyle of the femur, and now the posterior is attaching to the medial condyle of the femur, and if that is damaged, so the tibia can be pushed posteriorly, and that is posterior drawer sign. So this is posterior cruciate ligament, and if it is torn over there, like this is the posterior cruciate ligament damaged. The posterior cruciate ligament prevents the femur from sliding anteriorly on the tibia, particularly when the knee is flexed. So in the picture they are saying that the anterior cruciate ligament does not allow the femur to slide posteriorly. The femur, so it is one and the same thing, that the femur either it is sliding posteriorly or the tibia is moving anteriorly. It is the same thing, and opposite is true for the posterior cruciate ligament, that if there is posterior cruciate ligament, so the tibia will be moving posteriorly and femur will be moving anteriorly. So don't confuse yourself with that. Now let's move to the next thing, that is so the prepatellar and the suprapatellar bursas. What are them? So here you can see this is quadriceps femoris tendon, and this is patella, and between the skin and the patella we have prepatellar bursa, and then we have the patellar ligament, and between the patellar ligament and the skin we have deep and superficial infrapatellar bursa. So let's see that. Prepatellar bursa, between the superficial surface of the patella and the skin is the prepatellar bursa, like it is anterior to that, so it is prepatellar, means before patella. So prepatellar bursa is between the skin and the bone, that is patella, may become inflamed and swollen. Prepatellar bursitis can be there. Suprapatellar bursa. Okay, so superior extension of the synovial cavity between the distal end of the femur and the quadricep muscle and the tendon. Usual place of intra-articular injections may become inflamed when swollen suprapatellar bursitis. Where is suprapatellar bursa? Okay, so this place is the suprapatellar bursa. It is not a bursa per se. It is superior extension of the synovial cavity. Synovial cavity of what? Synovial cavity of the knee joint. If that synovial cavity is extended upwards, so that forms the suprapatellar bursa. Superior extension of the synovial cavity between the distal end of the femur and the quadricep muscle and tendon. Usual place of the intra-articular injections and may become inflamed and swollen. That is called as suprapatellar bursitis. What is knee jerk reflex? So the knee jerk reflex, here you can see that we strike the hammer on this patellar tendon. So the patellar reflex is tested by tapping the patellar ligament, that is not tendon, that's patellar ligament, with a reflex hammer to elicit extension of the knee joint. Both afferent and efferent limb of the reflex arc are in the femoral nerve, that is L2 to L4. So the patellar reflex is tested by tapping the patellar ligament with a reflex hammer to elicit extension at the knee joint. Both afferent and efferent limb of the reflex arc are femoral nerve. So femoral nerve is going to take the information, that is the afferent limb, and is going to take the information back for the muscle contraction as well, that is the efferent limb. So this is here you can see the quadricep muscle, the cell body of the sensory neuron, the dorsal ganglion, then the gray matter, and then the information is coming back for the contraction of the quadricep femoris muscle. So spinal cord. So sensory neuron, that is also present within the femoral nerve. Motor neurons are also present inside the femoral nerve, and then you have the internal of them. Okay, so knee jerk reflex tests spinal nerves L2 to L4. Okay, so it is something like the L2 to L4. Strike the door or something. So the knee jerk reflex is seen with so knee jerk reflex will test the spinal nerve L2 to L4. Okay, ankle joint injuries and ankle sprains. What are them? Sprains are most common ankle injuries. The sprained ankle is nearly always inversion injury. So the sprain injury, as you can see in this picture, the torn fibers of the anterior talofibular ligament. So mostly it is the inversion injury that is causing the sprain, involving the twisting of the weight bearing plantar flexed foot. The lateral ligament, anterior talofibular ligament, is injured because it is much heavier than the medial ligament. Okay, it is much weaker. It's not heavier, it's weaker. So why is that damaged? Because the anterior talofibular ligament that is present on the lateral side, that is much weaker than the medial ligament. So it is most commonly damaged ligament on the in the ankle sprains. In severe sprains, the lateral malleolus of the fibula may be fractured. Okay, so the lateral malleolus, like over here, this can be fractured in very serious kind of sprains, and this is the talofibular ligament over there. So that is a weak ligament, so it can be damaged easily. And the most common type of injury, the most common type of causative factor for the injury is the inversion of the foot or excessive inversion of the foot, you may say that. What is Port's fracture? It is the fracture, dislocation of the ankle joint. So if there is fracture or dislocation of the ankle joint, that is called as Port fracture. Reason: post eversion of the foot. So normally there is inversion, and that will result in sprain. A very severe sprain can lead to the damage to the medial fracture of the medial malleolus. Now, in case we have eversion of the foot, excessive eversion, like you can see in this picture, there is excessive eversion over here. So in that case, there will be fracture, multiple fractures, like these are the multiple fractures. So the deltoid ligament avulses the medial malleolus, and after that, fibular fractures are at higher level. So there will be a avulsion of the medial malleolus because there is deltoid ligament, I guess this one. So this will cause the medial malleolus of the tibia to be fractured, and the fibular fractures will be at a higher level, not at the level of malleolus, but at a bit higher. So here you can see these are the higher fractures. So the deltoid ligament avulses the medial malleolus, and after that the fibular fractures at a higher level. So initially there is damage at this point, and the secondary fractures are in the fibula, which are at a bit higher level. Injuries to the leg and foot fracture of the fibular neck. Injuries of the leg and the foot, injuries of leg and foot, and fracture of the fibular neck. So the first injury of leg and foot includes the fracture of fibular neck, which is happening on this side. It may cause an injury to common peroneal nerve, which winds laterally around the neck of fibula. So if the neck of fibula is being damaged, so resultantly the common fibular nerve or the common peroneal nerve will be damaged. This injury results in the paralysis of all the muscles of anterior and lateral compartments of the leg, dorsiflexors and everters of the foot. So the muscles which are present in the anterior and lateral compartments, they were supplied by the common fibular nerve. If that nerve is gone, so the nerve supply will be damaged. So resultantly there will be paralysis of all the muscles in the anterior and the lateral compartments of the legs, which are dorsiflexors and the everters of the foot. Resultantly, and losing the sensation of the dorsum of foot as well. So it will cause foot drop. As you can see in this picture, there is a foot drop, and to maintain that we ask the patient to wear this thing. So the patient have foot drop in the case of a damage to the neck of the fibula. Rupture of Achilles tendon, tricep shuri muscles. So if there is rupture of the Achilles tendon over here, like this is the Achilles tendon, so if that is ruptured, tendon Achilles with inflammation, and they can also be a rupture. So avulsion of the rupture, avulsion or rupture of the calcaneal or the Achilles tendon disables the tricep shuri. Tricep shuri, I guess it contains three muscles, the gastrocnemius and the soleus muscle. So these three things together, I guess, are called as tricep shuri. Let me see that. Tricep shuri, because we know one thing is tricep brachii, that is present in the arms. So tricep shuri, tricep shuri consists of two muscles located at the calf that are two-headed gastrocnemius and a soleus. So that gives three heads in toto. So resultantly we have tricep shuri, which contains gastrocnemius and the soleus muscle. Coming back, the avulsion or rupture of the calcaneal tendon disables the tricep shuri muscle so that the patient cannot plantar flex the foot. Okay. Tricep shuri muscles are two heads of gastrocnemius and one head of soleus muscle. Plantaris, small fusiform belly with a long thin tendon, sometimes may become hypertrophied, because when there is damage to these muscles, so plantaris muscle will become hypertrophied, and the person cannot, if that is damaged, so the person cannot plantar flex the foot. Okay, so that is an opposite of the injury to the common peroneal nerve, because in that case the person has an excessive plantar flexion, that is foot drop. But in this case the person cannot plantar flex the foot. So remember this thing, that if there is Achilles tendon damage, so the plantar flexion is lost. Then we have ankle jerk reflex. So what are we checking the ankle jerk reflex? We are hitting the Achilles tendon. Achilles tendon reflex is tested by tapping the calcaneal tendon or the Achilles tendon to elicit the plantar flexion at the ankle joint. Both afferent and efferent limb of the reflex are carried by the tibial nerve. So it is very important and easy as well that the afferent and efferent limb, both of them in the case of the knee reflex, which we previously have tested. So both the afferent and efferent limbs, they were taken by the femoral nerve. And now when we are talking about the Achilles reflex, so both the afferent and efferent reflexes are taken by the tibial nerve. So tibial nerve root value is S1 and S2, and ankle jerk reflex test the spinal nerves S1 and S2. Moving forward to the plantar fasciitis or calcaneal spur. What does that mean? Here we have the bursa node seen in the radiograph, and here is the calcaneal spur down that, below that. So plantar fasciitis is most common hind foot problem in the runners. It causes pain on the plantar surface of the foot and heel. Point tenderness is located at the proximal attachment of the plantar aponeurosis. Point tenderness is located at the proximal attachment of the plantar aponeurosis to the medial tubercle of the calcaneus and on the medial surface of the bone. Okay. Injury to the tibial nerve. So if the tibial nerve, where is the tibial nerve? So this is the tibial nerve. If that is injured, tibial nerve is one of the terminal branches of the sciatic nerve. So in popliteal fossa, loss of, so if the injury to the tibial nerve is inside the popliteal fossa, then there will be loss of plantar flexion of foot. Mainly gastrocnemius and soleus muscle are not working, so resultantly the plantar flexion will be lost, and weakened inversion will be seen. Tibialis posterior causing calcaneovalgus. Okay, so calcaneovalgus is a condition. What is calcaneovalgus? Let's see that. So calcaneovalgus. In the case of calcaneovalgus, we find that the foot is, calcaneovalgus foot is like extended upwards, and also calcaneovalgus is one of the most common deformities of the foot in the newborn. Babies with this condition are born with a foot and ankle excessively bent up, where the toes are usually touching the shin, and deformity may be present in the older children but manifestation of another condition. So they are saying that there is weakened inversion because of tibialis posterior muscle, and also there will be loss of plantar flexion. Okay, so that causes calcaneovalgus. Inability to stand on toes. Okay, loss of sensation and paralysis of the intrinsic muscle of the sole of foot. Loss of sensation and paralysis of the intrinsic muscle of sole and foot. Popliteal fossa from superficial to deep contains tibial nerve that is most superficial, then popliteal vein, and ultimately popliteal artery. So tibial nerve, popliteal vein, and the popliteal artery, these are superficial to deep structures which are present in the popliteal fossa. Then here you can see on the sole of foot there are two terminal branches of the tibial nerve, that are medial plantar nerve and the lateral plantar nerve. The medial plantar nerve supplies the adductor hallucis, the flexor hallucis brevis, flexor digitorum brevis, and the first lumbrical skin of the middle 3/5 digits. The lateral plantar nerve supplies all intrinsic plantar muscles which are not innervated by the medial plantar nerves, and the skin of lateral 1.5 digits. Okay, so the medial sural cutaneous nerve and the sural nerve over there, medial plantar, lateral plantar, and the medial calcaneal. So this is the distribution of the branches of tibial nerve. Then we have point number 20, that is about breast and thoracic wall and the intercostal spaces. The intercostal vessels and nerves, they run between the internal intercostal and the innermost intercostal muscle in the costal groove. They are arranged from superior to inferior as vein, artery, and nerve. So vein from superior to inferior, from above downward, they can be arranged intercostal vein and then intercostal artery and intercostal nerve. So they are moving between the internal intercostal and the innermost intercostal. Okay, they can be arranged like VAN, and most vulnerable structure in the intercostal nerve and the posterior intercostal artery. So the most vulnerable structure is intercostal nerve and the posterior intercostal artery, because they are not covered by the ribs. So posterior intercostal artery, the posterior intercostal artery and the intercostal nerve are not covered by the ribs. So they are the most vulnerable structures. Carcinoma of breast. So carcinoma of the breast are malignant tumors. Firstly, they're malignant tumors, usually adenocarcinoma, arising from the epithelial cells of the lactiferous ducts in the mammary gland lobules. As the cancer cells grow, they attach to the suspensory Cooper's ligament and produce shortening of the ligament, causing depression or dimpling of the overlying skin. So if these suspensory ligaments are involved, so resultantly there will be dimpling of the skin. Skin dimpling, this is skin dimpling, and dimpling of the skin over a carcinoma is caused by the involvement of retraction of suspensory Cooper's ligament. Skin dimple of a carcinoma, and there is a carcinoma over here basically. So this is a carcinoma, and this is the edema in the skin and connective tissue. Edema in the skin is depicted in this picture over here, and then connective tissue shadows are like that, and suspensory Cooper ligament is also involved by this tumorous mass. The lymphatic drainage of the breast, it is very high yield and very important as well. Clinically, it is important because of its role in the metastasis of the cancer cell. The most lymph node, more than 75%, especially most lymph, more than 75%, especially from the lateral breast quadrant, drains to the axillary lymph nodes, initially to the anterior pectoral nodes for most part. Okay, so anterior pectoral lymph nodes, what are them? The anterior pectoral lymph nodes. Okay, anterior pectoral. So these are pectoral lymph nodes. So anterior group of pectoral lymph node is the first one to encounter the lymph coming from the lateral lobes of the breast. So remember that most of the tumors of the breast are originating in the upper lateral quadrant, right? So the lymph from that quadrant is going to the pectoral group of the axillary lymph nodes. So most lymph, 75%, especially from the lateral breast quadrant, drains to the axillary lymph node, initially to the anterior pectoral nodes for most part, and most of the remaining lymph, particularly from the medial breast quadrants, drain to the parasternal lymph nodes or to the opposite breast. Okay, so from the medial breast, it can go to the parasternal lymph nodes or to the lymphatic drainage of the opposite breast as well. Okay, so 75% is being drained to the axillary lymph node, and 25% is being drained to the parasternal or the opposite breast. Okay, what is mastectomy? Mastectomy is, ectomy means removal. So mastectomy is the removal of a breast. Radical mastectomy, a more extensive surgical procedure, involves the removal of the breast pectoral muscle, fat, fascia, as many lymph nodes as possible in the axilla and the pectoral region. During radical mastectomy, the long thoracic nerve may be lesioned during the ligation of the lateral thoracic artery. A few weeks after surgery, the female may present with a winged scapula, okay, and weakness in the abduction of the arm above 90 degrees because the serratus anterior muscle has been paralyzed, which was being supplied by the long thoracic nerve. The intercostal brachial nerve may also be damaged during the mastectomy, resulting in the skin deficit of the medial arm. So the intercostal brachial nerve may also be damaged during the mastectomy, resulting in the skin deficit of the medial arm. Moving forward to the breast infection, that is mastitis. So mastitis is an infection of the tissue of the breast that occurs most frequently during the time of breastfeeding, 1 to 3 months after the delivery of the baby. The infection causes pain, swelling, redness, and increased temperature of the breast. It can occur when bacteria, often from the baby's mouth, enter a milk duct through the crack in the nipple, and most commonly it is Staph aureus that is causing the mastitis. It can occur in the women who have not recently delivered, as well as in the women after the menopause. So although it is most commonly associated with the breastfeeding, but it can happen in the women who have not recently delivered or in the women after the menopause. The diaphragm openings of the okay, so point number 21 is about the diaphragm and openings of the diaphragm. So there are 3 levels: T8, T10, and T12. So I ate 10 eggs at 12. This is a mnemonic from first aid. So inferior vena cava and the right phrenic nerve at the T8 level, inferior vena cava and then esophagus and right and left vagus nerve esophageal what that esophageal BR of left gastric vessels. So that is basically esophageal branch of left gastric vessel. Okay, so esophagus and right left vagus nerve along with the esophageal branch of the left gastric vessel, they are exiting at the T10 level, and the aorta, azygous vein and the thoracic duct at the T12 level. So the cable T8 transmit the inferior vena cava and terminal branches of the right phrenic nerve. Esophageal T10 transmit the esophagus, right and left vagus nerves, esophageal branches of the left gastric vessels, and the aortic T12 transmit the descending aorta, thoracic duct and azygous vein. So remember these three locations: T8, T10 and T12. T8 is the cable opening for inferior vena cava, T10 is for the esophagus, T12 is for the aorta, and also the other structures which are accessory structures which are passing through these things can be remembered over here. In the T8 level, we have right phrenic nerve along with the esophagus. At T10 level, we have right and left vagus nerve along with the esophageal branch of left gastric vessels, and at the level of T12, we have aorta, azygous vein and the thoracic duct. So we'll go to the paralysis of diaphragm. Paralysis of the half of diaphragm will be seen in the next session, inshallah. Until then, Allah Hafiz and fi amanillah.